chat. All right, well, welcome everybody to our Lunch and Learn Understanding the Brain-Gut Connection with Dr. Ali Navidi. It is our first Lunch and Learn of the new school year. My name is Olga Marable. I'm the Regional Director of Outreach for Fusion Academy. And for those who are not familiar with Fusion, we are a revolutionary private middle and high school serving 6th through 12th grade, where positive relationships unlock academic potential. All courses are one-to-one, one student and one teacher per classroom. This allows teachers to customize curriculum and teaching for each student's individual strengths, interests, and learning style. Our supportive campus environment is a unique space that includes a state-of-the-art recording studio, mixed media art studio, and a homework cafe where students complete their homework before going home. Flexible scheduling lets students enroll at any time of the year and take classes at any time of the day that works best for them. We also offer tutoring support, still one-to-one setting with over 250 course offerings. We offer a fine balance between academic as well as social emotional support through the homework cafe, clubs, and activities. We have 7 campuses in the DMV area, and that includes our Washington, D.C. campus, Loudoun, Reston, Tysons, Alexandria, Rockville, and Columbia. So I want to start briefly with a little bit of housekeeping. As I mentioned, this is being recorded. Feel free to turn your cameras off if you'd like, but also feel free to keep them on. Do keep yourself muted throughout the presentation. We don't want to distract the speaker. If you can rename yourself, just check and make sure that the name that pops up on your Zoom is your name and not your child or your spouse or random names and numbers. That way it's just easier if you ask a question, I know how to address you and who to call upon. The chat is going to remain open for the entire duration of the presentation. I would love for you guys to utilize it to collaborate, network, share your contact information. Please use it. And I will share it at the end too if there's any information that's going to be valuable for the entire group. Questions will be answered throughout the presentation. So feel free to pop your questions into the chat as I see them, and there's a good spot to pause. I can ask them on your behalf, and then we'll also hold them till the end. If there's anything at the end, we'll hold a Q&A. And the recording will be shared for everybody who is going to ask. I will share the recording with you after the presentation, hopefully by Monday at the end of the day at the latest. All right, so I'm going to start with a really quick icebreaker. I think it's a great way to get you guys to know each other, utilize the chat. So I just want to see who's here. So get ready in the chat. I want you to put in, and I'll actually throw it in for what we're going to do. Let me open the chat. I want you to put your name, your company and title if you want, contact information if you want, and what your favorite thing about fall is. And I'll go ahead and put mine in. My favorite thing about fall is sweater weather. As you can see, I'm already in it. I really wanted to wear my fall hat that's burgundy and super cute, but my husband said it'd be weird to wear a hat indoors, so I refrained. But would love to hear what you guys enjoy about fall, because I do think it's the best season of all. So go ahead and throw them in. Hi, Brenda, Keisha, Rebecca. The wardrobe choices. I agree, Brenda. Windows open at night, Andy. Yes. Cooler weather and seasonal teas. Oh, that's a good one. Pumpkin spice, fresh air. Yeah, anybody who's saying really good sweaters, TJ Maxx right now, on point, just saying. Halloween parties, Gina, love it. I don't like fall or winter, Keisha. That's okay. To each their own. I respect that. Good running weather. Yes, agreed. We're not super sweaty afterwards. It's a good breeze. Already started putting out the sweaters, Devin. Love it. Change of the leaves. And it's already happening. Are you guys seeing the leaves already falling? It's a really good time. We'll keep popping them in. Thanks, guys. I appreciate you indulging me in this. And I'm glad that you guys could to know each other a little bit better and exchange contact information. Today's speaker is Dr. Ali Navidi, a licensed clinical psychologist and one of the founders of GI Psychology, a private practice focused on helping patients with GI disorders and chronic pain. Without further ado, I'm going to go ahead and pass it over to him. And yeah, thank you so much.
Great. Thank you, Olga. And I appreciate, I appreciate the opportunity to let this group know about this information. It's something that I feel very strongly about, and I think it's important to get the word out, because not enough people know, and there's too many people suffering out there that could be getting some help. So let me get started and shift over to the PowerPoint. So share screen. Okay, is that looking good? Great. Okay, so today I'm going to talk about disorders of gut-brain interaction, that's DGBIs. And these are what used to be called functional GI disorders or functional GI problems. We're going to talk about treatment of DGBIs, and then some practical considerations in terms of clinicians and therapists. And then my PowerPoint likes to get ahead of me. And then if we've got time, we're going to do a little extra bonus session. And I'll tell you about that if we have time, because I don't want to disappoint you. So like Olga said, I'm a clinical psychologist, and I've been doing this kind of work for 12 or so years now, working specifically with chronic pain, with GI problems. And about 2 years ago, we started a private practice called GI Psychology, and the website's pretty simple, gipsychology.com. And we've got a lot of resources on there. And we're a telehealth only practice, and we treat from basically 6 years old up. And because of SIPAC, which is changes in laws for psychologists, we're able to treat patients in about 30 states. I do the training, and I also do the outreach, so what we're doing right now. And really the mission of GI Psychology is that, I've been working in this field, doing this work for a long time. And there are very, very few people, very, very few clinicians who are trained to do this work with these patients. And so what I found is that eventually there weren't any options for them other than myself. So about 2 years ago, we started the practice, and the goal is fairly simple. We want to improve access to care. So training more therapists to do this work, and then also educating professionals like yourselves that these treatments are out there. And so that's what we're going to do today. So starting with what are disorders of gut-brain interaction? And by the way, the change in the name has been amazing, and that's been fairly recent. So it used to be called functional disorders, and now they're disorders of gut-brain interaction, which is awesome because it puts the problem right in the name. The way that the gut and the brain are interacting, communicating with each other is where the problem is coming from. So what that means is you're not going to find inflammation, you're not going to find ulcers. These aren't those kinds of problems. You're not going to find structural problems with these DGBIs. And so they include things like irritable bowel syndrome, or IBS, which is patients who have diarrhea or constipation and abdominal pain, or something called functional dyspepsia. That's pain or burning in the stomach, bloating, belching, nausea, feeling really full. And then also pain can be associated with that. I'm just reading these symptoms off, but take a moment, and you might know, these are extremely common disorders. And so you probably know someone with these problems, or you might have some of these problems yourself. and they are tremendously difficult to live with, because in a sense, it feels like for the patient that their gut has turned against them and they can't trust it anymore. When they eat, often there'll be pain, often there's negative effects. It really can consume someone's life. And when we're talking about a child or an adolescent, it's even rougher, because now you're having trouble maybe going to school or doing activities or going to the pizza party. So I wanted to kind of give a sense of these disorders. While there isn't any structural problem happening, they really impact people's lives in a very profound way. And so I went into detail in 2 of these functional disorders. There's about 22 different types. And you can check this out. This is the Rome Foundation. And you can look up their website also. And what they do is they set up the criteria that doctors across the world use for functional GI disorders. And if you ever want to learn more and kind of do a deep dive, the Rome Foundation is a great resource. So Olga, any questions so far?
Yes, you will. We're not going to send a copy of the slides, right? Just the recording.
I don't think so.
Yeah, Victoria, but you will get a copy of the recording, which will include all the slides. That's it.
Yeah, we're going to go through all the slides, so you'll essentially have all the slides. And so when we're talking about DGBIs, functional disorders, in a way, you could think of it as a dysfunctional marriage. If you've ever known anyone who's in a dysfunctional relationship or have ever been in one yourself, the 2 partners kind of will amplify each other. So the problems aren't just in the brain and the problems aren't just in the gut, but they amplify each other to create this negative effect that happens in the body. And I'm going to kind of go through how that works in a little bit. The thing to know, though, is even though they're functional, even though there's no structural damage or issues, the pain and the symptoms are 100% real. And too often, patients or kids, they're told in different ways that this is all in their head. And it 100% is not in their head. It's in their head and their gut. And because the gut is involved, we see real physical symptoms. When people are trying to figure out whether they have a functional disorder, it can be a difficult road. And so what often happens is that a patient will, develop pain or constipation or diarrhea, and they'll go through test after test. They'll end up with a gastroenterologist, potentially months of testing to basically exclude all the other diagnoses. And then they kind of land on, okay, this is a functional disorder. So there's no like one test that they can say, oh, we got it. This is functional dyspepsia. It's more like they have to do an assessment to figure out what it's not. And so we see changes in the GI system, in the brain. And some of these changes are motility disturbances, how fast things are moving through the GI system, visceral hypersensitivity, which we'll talk about more, altered mucosal immune function, microbiota, and CNS processing. So we're seeing changes that are happening because of this gut-brain interaction. And that's why I said the pain and the symptoms are 100% real. It's not in their head, but the head and the brain is very involved in the problem. And I mentioned earlier that these are very common disorders. A recent epidemiological survey that I was looking at, and I don't know if I even quite believe this. There's some conflicting numbers, but it's saying about 40% of, if you're looking at world population, have at some point had a DGBI. And if you're saying at some point, that makes sense. But either way you cut it, these are extremely common. We're guaranteed to have some people here right now in the talk who have a DGBI, and at the very least, everyone here knows somebody who has one. If we're just looking at one of the more common DGBIs, or at least well-known, we've got IBS, 3 to 5% prevalence rate. And that's 16.5 million Americans. It's costly in terms of quality of life and just in terms of medical care. So if you're a clinician, if you're working with clients, if you're working with patients, I want to take a second here just to encourage you to ask some questions when you're getting to know your client or your patient, to ask some questions that maybe you wouldn't always ask, asking about chronic pain, bloating, nausea, chronic diarrhea or constipation. If you're getting a sense that there's a lot of foods that they avoid, because that's something that frequently happens. People will start avoiding different foods because they believe that it's making their symptoms worse. And then of course you want to rule out eating disorders and then also disordered eating. And if you're starting to get yeses to some of these questions, just finding out, have they had a good GI workup? Because that is important, like I said earlier, to rule out some of the more dangerous stuff. And as a clinician, again, if you want to learn more, this is what I was talking about earlier, the romefoundation.org. So I'll pause again for a moment and see, Olga, if there's any questions. Okay, great. So let's look at the model. And this is a general model that looks at different DGBIs. And there's 3 things that are important to look at in this model. First is something called the brain-gut axis. And that's something that's relatively recently been studied more and more scientifically. And that is this very powerful connection between the brain and the gut. And in a sense, you could consider it a connection between the central nervous system and the nervous system that is in the gut. Some people don't realize that the gut has its own nervous system. It's called the enteric nervous system. And that's led some people to talk about the gut as kind of the second brain, because it's got its own nervous system. It's got all the different chemicals that are going on in the brain, neurotransmitters. They're happening in the gut too. And so to some extent, that leads to this powerful back and forth connection, meaning what's going on in the brain can powerfully affect the gut, and what's going on in the gut can also affect the brain. We're not going to talk so much about the gut influencing the brain in this talk, but know that's an exciting area of research. A lot of people are looking at that right now. But the brain also, as you know, now very powerfully affects the gut. And then the other big factor in almost all these disorders is what's called hypervigilance or catastrophizing. And this is a very specific type of anxiety. It isn't generalized, but it's very focused on the symptoms. So what you see is patients who are constantly scanning their gut. They're constantly looking, noticing what it feels like. If they notice something, then they're, oh my gosh, what's going to happen? Is it going to get worse? Am I going to have problems? And if they are having problems, if there's pain, bloating, discomfort, they're worrying about it getting worse. They're worrying about it ruining their day, their time, their events. And so all of this anxiety that's happening gets fed down, as you can see here, just fed down into the gut. And what does that do? Because of the brain-gut axis, it actually makes the symptoms worse. And so the worrying about the symptoms make the symptoms worse. Similar to the type of model you'd see with a panic disorder. Then that's not all, because then what you see on the gut side is something called visceral hypersensitivity. And in essence, what's happening is, there's sensations, there's feelings in the gut that of course get transmitted to the brain. But when there's visceral hypersensitivity, those sensations are amplified, and often amplified in a negative way. And one of the ways I describe it to patients is, imagine you're listening to music on some headphones, and as a joke, somebody just cranks the volume really high. Even if it's good music, it's going to be painful, it's going to be uncomfortable, you're not going to enjoy it. And that's what's happening here in the GI system is there's actually the sensations that are happening for the most part are going to be neutral. But because of this visceral hypersensitivity, they get turned into pain, discomfort, negative sensations, which then gets processed by that hypervigilance and catastrophizing and amplified for more stress. So you can see in this system how it kind of feeds itself. Once these disorders are established, these three factors, the brain-gut axis, the hypervigilance, and then the visceral hypersensitivity, it feeds on itself to create more and more symptoms. So questions about the model?
I do have a few questions in the queue. So the first one is from Rachel. Have you ever seen a connection with pseudo seizures?
Yeah, so pseudo seizures are fascinating. And so if you're looking at, in a way, the broad category of psychosomatic disorders, where you're having, the brain is having a powerful effect on the body, pseudo seizures would be an example. In terms of DGBIs, what we find in general is that patients with DGBIs tend to have more chronic pain or chronic health issues that are often related in a psychosomatic way. So for example, someone with IBS might also get chronic headaches. They might have joint issues. They might have kind of a brain fog or chronic fatigue that are not medically explained, that doctors cannot find any causal mechanism that's going on in their body. That's not to say everybody with, let's say, IBS is going to have those things, but often they do. And so I haven't looked specifically at pseudo seizures related to DGBIs, but it wouldn't be surprising to me at all if there was some kind of correlation, seeing a little more of that happening. Any other questions?
Two more. From Shalina, any of these GI issues connected to ARFID?
So we're talking about like avoidant restrictive food intake disorder. I think I got that right. Absolutely, that's an awesome question. What we see often is people are making kind of incorrect assumptions, or we could call it conditioned responses. And I'll give you an example. Let's say someone with IBS, eats some pizza, and for whatever reason that day just happens to be a bad day for their symptoms. Well, what's going to happen is they are going to unconsciously and or consciously associate pizza with problems. There might not be, and there probably isn't any physiologic reason that their GI system can't process pizza. It can't process cheese or sauce or the bread. But once that conditioned response is established, then next time they eat pizza, there's going to be more hypervigilance, there's going to be more catastrophizing. And as we know, that stress is going to go right down into the GI system. They're going to have more trouble digesting it. And it's going to be kind of, it's going to be self-fulfilling at that point. And then they're going to be very convinced that pizza is a problem. And so when we're talking about ARFID is an eating disorder where it's not based on, let's say, body image or something like that. It's based on other factors the patient is restricting. And so you could see just with the pizza example, if you took that with pizza and then you just keep doing it with other foods over time, you'll see some of these patients with IBS or other DGBIs have an extremely restricted diet. And sometimes it can get to the point where it's clinically, the diet itself is clinically significant enough that they would meet the diagnosis for ARFID. In terms of treatment, when we treat patients like this in GI psychology, one of the things we do is, we put them through the protocol, let's say for treating IBS. At the end of it, they're successful with the treatment. Then we can kind of clean up the food, meaning now that we've treated the DGBI, we can go back and start reintroducing the food because they're not having this cycle of reaction. They can introduce the pizza again. They can start eating the whatever it is that they took out of their diet. So anyway, great question. Hopefully, maybe I answered it too much, but any other questions?
There's one more from Marlene. Will you be able to talk a little bit about autism and the brain-gut reaction?
Yeah, absolutely. So what you see is a higher prevalence of DGBIs in the autism community. Patients with autism spectrum disorder tend to have more DGBIs, whether it's IBS or it's functional abdominal pain, whether it's nausea. And so, this, and again, the one message I want to kind of make clear throughout this is these are very, very treatable. These patients don't need to be living with these problems the rest of their lives. And the earlier we can get them treated, the better. It's easier to treat the 11-year-old who's just developing these issues versus the 47-year-old who's had the issues for many, many years. We treated many patients on the spectrum. They respond to treatment pretty much just as well as anybody, as long as they're at a certain level of functioning. They need to be on the higher level of functioning in order to benefit from the type of treatment that we're offering. Cool. Any other questions? This is good stuff. I like questions. So we're talking about psychological, like how do we treat this kind of cycle when it gets established? There's two mainline treatments for this: cognitive behavioral therapy and clinical hypnosis. But I want to talk a good amount more about the details of that. So for cognitive behavioral therapy, just kind of the basics. Okay, what is CBT? What we think and what we do is important. It affects how we feel. It affects how we act. Of course, there's a lot more to CBT, but that's just kind of the broad explanation, because I feel like most people know at some level what CBT is. Now, the important thing to cover, though, is it's not just any CBT. So just like there's specific CBT protocols, for example, like CBTI for treating insomnia, and then a clinician needs to be trained on whether I'm CBTI trained or not is going to make a difference. This kind of work also relies on that. So there's specific protocols for treating IBS or functional abdominal pain or chronic pain with CBT. So the problem is often doctors will read, okay, CBT is effective for IBS. Let me send my patients to the local CBT therapist. And it's not as if it's a bad thing, because the therapist will be able to help them with anxiety or depression or any of the kind of standard stuff And there is a lot of comorbid anxiety and depression that go along with DGBIs. However, the therapist more than likely won't know how to specifically treat the DGBI with their CBT because, again, there are specific protocols. How does it help? Well, in general, CBT is going to reduce the anxiety and depression. And so you're not going to have those secondary, those mental health disorders kind of adding stress to the system. It's going to build resilience and emotional regulation. That's going to reduce stress also. If we can reduce the hypervigilance and the catastrophizing, that's going to be helpful. And then there's often a lot of avoidance. And so I was talking a little bit about the avoidance we see with foods, but there's also a lot of avoidance in terms of activities. So if you're talking about kids and adolescents, they start missing school, or they start cutting down on their activities, or they don't go to the sleepover. And so you see and you see this with adults too, but you see a constricting of their world. And, as most of us know, when that happens, that is going to make them more vulnerable to other mental health problems. And so that's just still going to add more stress to the system. And so part of that work is to get them out of that avoidance cycle. Okay. Now, the other mainline treatment is clinical hypnosis. And I usually get a lot of questions about this one, and I'm super happy to answer all of them, because one of the things I really like to do is to get the information out about what clinical hypnosis is versus entertainment hypnosis. And the problem we have is that everybody knows what entertainment hypnosis is, and very few know what clinical hypnosis is. So entertainment hypnosis is like the movie that just came out. There's always another movie that has, mind control or some kind of witchcraft or magic hypnosis being used for that. And it does make me feel kind of bad, because there are these researchers out there who have been studying clinical hypnosis for DGBIs, for chronic pain, for many, many years. Like the research behind, let's say, you just clinical hypnosis for IBS. There's over 30 years of research. I know at least over 100 studies, good, controlled studies in reputable journals, study after study after study showing it's effective and it works. And all of that hard work gets overshadowed by the latest movie, or there are these stage hypnosis shows that go around colleges and high schools. All of that gets overshadowed by that, which is a shame. So let me pause and check with Olga and see if there's questions so far.
There are two. So one is, would love to know your thoughts on functional neurological disease indicative of non-traditional tics and how it relates to GI psych.
Yeah, I mean, I think because in the question you're using the word functional, I'm going to assume then that it goes kind of in the same category of what we're talking about. There isn't structural, they're not finding a structural reason for the problem, and that there's an interaction happening between the brain and the body. In this case, tics. I have treated these kind of functional tics before. A lot of similar treatment methods that are used for DGBIs can be helpful for these types of problems. It's one of those things where, and this is why when I say what we do GI psychology is, the GI disorders and also chronic pain, because the techniques that I'm outlining, I'm talking about CBT, I'm talking about clinical hypnosis, are very effective in general for these mind-body problems. So if we're talking about functional tics, or we're talking about pseudo seizures, we're talking about DGBIs or chronic pain, headaches, things like that. These are very helpful techniques for these types of problems. You said there was 2 questions, right?
Yes, one more from Stephanie. I saw that you treat POTS. Could you elaborate on that?
Yeah. So POTS is a very challenging condition. There's a lot going on with POTS. If I say what the acronym means, I think I might mess it up. So I'm going to leave it to everyone else to Google it. But it's like postural orthostatic tachycardia syndrome. Maybe that's right. But anyway, POTS requires a team. There's a lot of different problems going on with POTS. And we're part of that team. And so frequent symptoms that you see with POTS are functional GI problems. You also get a lot of headaches, and you get a lot of joint pain. So in general, you get a lot of chronic pain, and we can help out there. But like I said, we're not the only one treating POTS. There needs to be a team approach, and it's a challenging condition to have. So I'd encourage, if you know someone with POTS, make sure they have a team supporting them to get that help. And then, are we good with questions? Okay, great. So I'm shifting over to, okay, so we know what hypnosis isn't, so what actually is it? It's actually a very natural thing. So it's essentially teaching somebody how to go deliberately into a state of consciousness called trance. And the nice thing in terms of my job is that trance is happening all the time. Meaning, I drove here, to the office, drive the same way every day. I turn on my my podcast, and then suddenly I'm at the office. I don't really remember the drive, but I do remember the podcast. And so that's an example of just a trance that's happening. If you're listening to this lecture and then you find your mind is wandering, you're daydreaming, another example of trance. Athletes go into trance very frequently. They'll be playing a soccer game, they'll be, doing their sport and get done, and then notice they've got a bruise or a scrape or a bloody knee, and they didn't notice it happening. And so the thing to realize is trance is happening throughout the day. Just look at a teenager on their phone, and you'll see trance happening. And so what we're doing is just teaching people how to do something on purpose that they're doing throughout the day accidentally. And the reason we care about trance is that when people are in a state of trance, they have enhanced capacity to kind of influence that mind-body connection. And that is where we can, and going back to the model, that's where we can alter that visceral hypersensitivity. And I don't know of any other treatment that can directly influence that. So we've got our model here, and we can see that it directly affects that visceral hypersensitivity. Using trance, you can relax smooth muscle. That's muscle that usually is not under conscious control. There's something called hypnoanalgesia, which is basically the ability to kind of reduce the impact of pain, sometimes even eliminate it. And then also using trance, using hypnosis, you can very powerfully control attention. So essentially teaching somebody how to focus on other things so that they're not adding into that hypervigilance catastrophizing cycle. And one of the things, and I want to go back for a second, one of the things to understand about hypnosis, all hypnosis is self-hypnosis. And what that means is is if I'm showing someone how to use hypnosis, I'm more of a coach than I'm like doing something to them. I'm coaching them through, and they can listen to what I'm suggesting, or they can do their own thing. And that happens all the time. And so when we're using clinical hypnosis in treatment, every patient is going to learn self-hypnosis. And that is incredibly empowering. And what I tell my patients is that you're coming in, let's say, for this chronic pain or IBS, and you're getting a bonus. And that bonus is you're going to know how to use self-hypnosis for the rest of your life, whether you want to use that to help with some pain, to help with some behavior change, or even just to help yourself relax and feel a little calmer. Clinical hypnosis, going into trance, is very calming. It's a great affect regulation technique. So, any questions about that? Okay.
Nope, one just popped up. Robin, is self-hypnosis helpful in patients whose sleep is disrupted or delayed by their symptoms?
Yeah, absolutely. That's probably one of the first things that you see people using self-hypnosis for when they learn it. Even before, let's say I'm introducing and teaching someone how to use hypnosis, before I even teach them how to use it for pain, we're going to show them how to use self-hypnosis, and they're going to use it for sleep. And it tends to be very effective for helping people fall asleep. And that's often a secondary issue with people with anxiety or people with chronic pain or people with a DGBI, is that their sleep's been disrupted. And of course, we know that when sleep is disrupted, everything gets worse. You know, mental health gets worse, your physical health gets worse. And so most patients, even just without even me telling them, they're able to use self-hypnosis for just to help them fall asleep faster. Any other questions?
Right, from Dan, difference between hypnosis and meditation.
Good question, Dan. So they are very similar in the sense that for the most part, meditation is accessing that trance state. The difference is what we're doing with the trance state. So as an example, the metaphor I like to use is if somebody injures their back and they're going to go to the doctor, and the doctor says, okay, you need to do physical therapy. So, okay, they go and they get the physical therapy, and they're getting very specific exercises from the physical therapist to address that back pain. And let's say the physical therapy works and their back is better. And now what's recommended is that they have just a general fitness routine, that keeps their core strong and keeps their mobility up, just a general good physical health. And so the meditation versus clinical hypnosis would be more like the PT. We're very targeted and we're very focused. And we're giving suggestions about pain. We're giving suggestions about anxiety. We're giving suggestions maybe about the bloating. Whereas for the most part, and there's definitely exceptions because there's hundreds and hundreds of different types of meditation. But for the most part, meditation is more general in the sense that it's going to make people just generally healthier in terms of their mental health, generally healthy, generally more resilient. So did that answer that question? Okay, any other questions? Okay, great. So looking a little at the research, and like I said earlier, there are hundreds of studies. If you go to, PubMed, type in clinical hypnosis, IBS, you're just going to get, pages of stuff. And all of it is showing that it's effective, showing that it works. Similar to CBT. CBT is also have tons of research supporting the work with DGBIs, these types of problems, and it's effective as well. So this is an example, of a patient. They're just showing with functional dyspepsia, and you can see this is compared to standard medical care. Here's another study. This is a patient with IBS, and you can see you get just significant improvements in symptoms. And the research for clinical hypnosis and for CBT is at the point where they're not even trying to research whether it works or not. It's been very firmly established that it has. They're at the point where they're doing these big reviews of all the different studies that have been done, and they're looking even deeper now, which I'm not going to get into in this talk, but they're looking at, where in the brain is changing when you're using clinical hypnosis to help someone with pain, those kinds of things. So the research on this is very mature. So you can see a comprehensive review showing it's highly, clinical hypnosis highly effective. Another one showing that CBT and hypnosis significant improvement. So over and over again, you're just going to see research after research. Another cool little thing that I'm not talking too much about in here is what happens if you combine CBT and clinical hypnosis. And people have done the research, they've looked at that, they've integrated those two types of treatments. And what they find is that it makes the CBT more effective. So for example, if you're treating an anxiety disorder and you're integrating hypnosis into the CBT, it just becomes more effective. So any questions about that? Okay, great. So just some kind of standard examples that we see. Often you'll see patients that already have anxiety. Patients that have anxiety are more likely to develop DGBIs. And the other way around, if someone has a DGBI, they're very likely to also have anxiety. And then also you see a lot of patients who are in the middle of school refusal. So they're having trouble getting to school. I can think of a patient that ended up going to Fusion, and it worked out really well for them, that I was working with, that had a DGBI. And so, because when you have anxiety and you have a DGBI, so they're having physical symptoms like this, it takes it to a new level in terms of anxiety about going to school. And that can be really hard for patients to break out of that without some help. You see a lot of patients that have chronic pain, headaches, joint pain. AMPS is, I believe, amplified muscular pain syndrome. I might be getting that slightly wrong. But that's another psychosomatic disorder that's very powerful. They get really intense pain. And so often there's DGBIs associated with that. These are all maybe you'd say like typical patients that we see at GI psychology. So any questions before we shift gear? Okay.
We have two. All right. First one from, can you speak to how food allergies may co-occur with some of these conditions and anything to be considered in those cases?
Yeah, and I think that's an important thing to consider is, it can be a very complicated mix. And so as an example, I can think of a patient that I treated years ago. They had a food allergy, they didn't know it. And, they ate a lot of that food, ended up vomiting. and then ended up developing a phobia for vomiting based on that. But then that got applied to food. So in essence, they developed RFID. So what happened is they were just terrified of eating the wrong thing and ending up vomiting. That terrified them. And so they were constantly scanning their gut, looking for any signal that maybe they had eaten the wrong thing, maybe something wasn't working right. And so, of course, that led to more stress, which led to more symptoms. And so, of course, they went and got tested and they had some food allergies, but, they had this much food allergies, and then they had, this much restriction in terms of what they would eat. So in essence, they were, maybe allergic to 4 or 5 things, and they were restricting like 40 things. And so part of treatment was first treating, we needed to treat a lot of things. We needed to treat the phobia, we needed to treat the DGBI. And then once we were able to do that, then we could start reintroducing the foods that they could eat versus the foods they were actually allergic to. So it was a very complicated mix. And the fact that there were real allergies there just added to the complexity, because there was definite negative reactions if they were to eat those things. Okay. Any other questions?
I have 4 more. Do you want to answer them now? Okay.
Yeah. Because next, I think we've got time. Next is our bonus fun time.
Perfect. Okay. All right. So we'll get through these. Victoria's question. Do you have research that shows effectiveness of this compared to work with diet nutrition? Because I see that so many people focus on food and diet, but I think until people tease out the mind-body connection, they can't fully know this. But are there statistics on this?
Yeah. So as far as I know, and I'm not the diet expert, but I was at a event the other day with a lot of dietitians, and I speak to dietitians frequently. So there's essentially one diet that's had any research associated with it. That's called the FODMAP diet. And this has specifically been tested for IBS, but I think it's also used for other DGBIs. And there is some research showing it's effective. There's a little controversy about that research. Some people claim that there haven't been enough studies done showing it's effective. But so you could look at the research surrounding FODMAP if you're interested in learning more. From my own clinical perspective, I've seen that diet only helps so much, and frequently people over focus on diet, and I think they do because it has a lot of face validity. It makes sense. If I'm eating food and then my stomach is bothering me, then it's probably the food. And we've gone through most of our lives understanding that kind of basic idea. And the problem is with DGBIs, that breaks down, because fundamentally, it's not the food that's causing the problem. Like I said at the beginning, the name speaks for itself: disorders of gut-brain interaction. And so it's not based on food. And so there are some diets that can help a little, but for the most part, the patients that go down that diet rabbit hole, they're not focusing enough on that brain-gut connection, on doing the things to break that cycle that I showed you earlier. So next question.
Okay. Dan, this question: what professionals do you recommend for a full GI workup? Gastroenterologists, and what else?
I would say gastroenterologists. I think that you can go to primary care, and they will, I think for the most part, be able to rule out all the danger signs. Usually the things that are the scariest, and and there's certain tests that they can do, usually blood tests and things like that. And they'll do an interview, a clinical interview, and kind of determine, okay, hey, this isn't one of these really dangerous things. And the field has evolved. So when I first started, in order to get to a diagnosis of, let's say, IBS, patients had to go through months and months and months of testing. And it was really rough on them because obviously nothing was being done for their symptoms. And so nowadays, based on new criteria, the doctors, the physicians are now empowered to be able to diagnose IBS pretty much just from the interview and a few simple tests. And when I say simple tests, I mean like they're not having to scope you, endoscopy, colonoscopy, really invasive, difficult tests versus, taking some blood. Now they're empowered to diagnose a DGBI based on those kind of interviews. So we've evolved in that. So now patients don't have to necessarily go through months and months of testing, and we're getting the referrals earlier in their process, which is great, before they've kind of been put through that cycle, because it's rough on the patient. I mean, think about it. You've got all this pain and you've got all these physical symptoms, and you're hoping after each test, are they going to figure it out? Are they going to figure it out? And they never do. Each test comes back, we're not finding anything wrong. And that goes on for months, and they've got this pain. And now they can be told pretty much near the beginning of this journey, we think we know what you've got. This is a DGBI, and this is how we treat it. And we know the treatment works. And in case, I don't think I mentioned it, the treatments that we use, let's say the protocols for CBT or clinical hypnosis, we've got a very high positive response rate. We're talking about like 75 to 85%. And the 85% tends to be for the younger ones. Like if you're getting people, I think under 13, it's like an 85% positive response rate. And then when they get a little older, the response rate goes down a little bit to 75%, but it's still very high in terms of treatments. And the nice thing is we don't just have one protocol. Okay, if this protocol doesn't work, we can try another protocol. We can try another protocol. And that's kind of the benefit in that we focus intensely on this kind of work. Next question.
All right, next question from Candace. What about dementia or Alzheimer's?
I don't really know much in terms of DGBIs and correlation with dementia or Alzheimer's. Yeah, that's something I don't have much to add on that one.
All right. All right, and the next question, the last question is from Claire. What's the difference between disassociation and clinical hypnosis? I have a teenager who disassociates due to trauma. So when you're talking about hypnosis to help not focus on the pain, it seems similar to disassociation.
That's a super cool question. And, so disassociation is another cognitive function that occurs in everyone. And it can become dysfunctional for various reasons in various people. And often it can become dysfunctional in patients with a trauma history. So they might have PTSD or they might not, but dissociation can become dysfunctional, meaning it's happening outside of their control. The intensity of it isn't working for them in their life. It can be also related to flashbacks and things like that. The nice thing about clinical hypnosis as it relates to that dissociation is that dissociation is something that often happens in trance. And so the cool thing is, so if a patient comes to me and they've got trauma-related dissociation, this is good news for them. So A, they're gonna often be very talented in terms of hypnosis. And I realized I forgot to talk about hypnotic susceptibility and hypnotic talent. So after I get done with this, I'll just throw that in really briefly. But patients who are disassociating due to trauma very often are very good at hypnosis, good at going into trance. And the nice thing is what we can do is teach them how to disassociate deliberately, so we can bring that disassociation under conscious control, which is so helpful for them because it can be a very disturbing thing. And disassociation can take many forms: derealization, depersonalization, flashbacks, things like that. But learning clinical hypnosis for someone who disassociates due to trauma is very empowering, because they can take kind of control over that. And then, like I said, okay, going into susceptibility and hypnotic talent. One of the common thoughts people have when they hear about clinical hypnosis is, oh, well, I don't know if I would be able to do it. Maybe I'm no good at it. Or another one I hear is, I'm too strong-willed for that to work. And the strong-willed thing kind of misunderstands what hypnosis is. It's not about someone controlling your will. It's not about taking control from someone. It's actually about teaching someone how to control their own inner world more effectively. So that's just one common misconception people get. But are you going to be good at it? And so the researchers have studied this. If you're looking for research on this, it would go under hypnotic susceptibility. I do not like the word susceptibility because it implies, again, this kind of control aspect. You're susceptible to some sort of thing, which I, again, do not think is what's really happening. I like the term hypnotic talent. And so what they found is, for the most part, it's a bell curve. So if you look at the population, there's going to be a few people out there that are just terrible. You know, it's like talking to a brick wall. They have such a hard time with it. Then there's a few people out there that are amazing at it. They're kind of the hypnotic virtuosos. And most people are going to be in that, you know, the fatty hill in the middle. Basically, they're kind of middle of the road, and that is fine. In order to do work with DGBIs, in order to help them with anxiety or chronic pain, we just need them to not be terrible. We don't need them to be amazing. So hopefully I answered that question. That was a lot of talking.
All right, next question is from Stephanie. It's a really good one. Did you say that patients should or should not get a full workup before working with a GI psychologist? You mentioned starting with easy tests. At what point do you stop testing?
Yeah, and that can be a problem depending on how educated your doctor is. There always can be another test. And that's one of the dangers in terms of our medical system, is that if you go to enough doctors, there are always going to be another test for you to do. There's going to be another drug for you to try. There's going to be another treatment. And depending on the problem, sometimes there's going to be surgeries, not usually with DGBIs, but that often happens with chronic pain. So we don't need it to always be a full workup, meaning they've had every test, they've been scoped up, down, left, right. That's not required. What we need is a physician kind of checking them out, going through and at least saying, okay, we know it's not these dangerous things. And they can reliably say whether, you know, if they're kind of educated on now the modern way of diagnosing things like IBS and things like that, they can do that relatively easily. So we don't need the full workup. We just need a physician kind of laying hands on them, saying, okay, they're clear to do this treatment. And patients can even start this treatment while they're getting some of the other tests done. because the doctor can say, look, based on what you're saying, based on what I'm seeing, I'm almost 100% sure that it's a DGBI. Get started on this treatment. And the treatment is short, by the way. It's like 10 sessions or something for most of these DGBIs. They'll say, get started on the treatment. There's a few other little tests that we're going to do for you. I don't think anything's going to come of it, but we're just going to do it to be sure. But you can get started on the treatment. And so that's what we're seeing nowadays versus when I was first doing this, all the patients had these full workups that lasted months. So great question. Oh, any other questions?
That's it. You gonna do your fun stuff?
I think we're gonna need to do some fun stuff. So let me grab a quick drink. So Olga has bravely volunteered to be our test subject for hypnotic talent. And Olga, do you have any experience with clinical hypnosis?
I do not.
Perfect. And so what we're not doing, we're not going to be teaching her how to go into trance and use hypnosis fully right now. That's not what we're doing. What we're going to do is we're going to play a few little games, and these games are going to give us a sense of Olga's hypnotic talent. And like I said earlier, when we look at the population, chances are that she's medium. She's right in the middle. That she's not a hypnotic superstar versus someone who just can't work it for herself. And by the way, the hypnotic superstar, what does that mean? So I went to a hypnosis training a while back, and the person teaching the training was someone who did a lot of work with cancer patients using clinical hypnosis. So you could see why that would be the case, because hypnosis is great for nausea, it's great for chronic pain and things, and anxiety, of course, and stress are going to be going along with it. So anyway, her story was that she discovered hypnosis when she was much younger. She had had a surgery done, and something went wrong in the surgery, and she reacted really badly to the anesthesia, to the point that she almost died. And so, but she survived. And then afterwards, she developed, I think it was some kind of hernia. It was a very painful condition. And the problem was her and her doctor were not very keen on, rolling the dice to see if she would have that reaction to anesthesia again. So she kept putting off the surgery, but it was a very painful condition to live with. So at some point she discovered clinical hypnosis, found out that she was just amazing at it, and essentially decided, hey, I'm going to go get this surgery without any anesthesia at all. And her doctor was kind of, her primary care doctor was kind of like, okay, I got to go and see this. And so took a video camera to the surgery and videotaped her getting the surgery done. And the video's on YouTube, and I can send the link out through Olga if people are interested. And it shows her with her eyes open, getting the surgery done, asking questions of the surgeon, looking very calm, very relaxed as they're opening her up. It's not for the squeamish, because they're showing what's happening in the surgery in this video, but it's an illustration of what does it look like when someone has a lot of hypnotic talent. So any other questions before we go forward and have a little fun?
Yes, two. So would you say that a colonoscopy endoscopy is not necessarily needed?
Yeah, so obviously I'm not a gastroenterologist, and they're going to do their own assessment. What I do know from talking to gastroenterologists is that in general, not speaking to any specific case, in order to diagnose something like IBS or functional dyspepsia or functional nausea, functional abdominal pain, things like that, the scopes are not required. The scopes are required if there is some indication that there's some other serious things going on that they need to rule out. And for the most part with IBS and things like that, there are not those indications. But sometimes there are, and they do the scopes and they don't find anything. And it does end up being IBS or some other functional disorder or a DGBI. So that's a good question.
And then a very practical question from Jamie. Does insurance cover this type of treatment?
Very practical question. So insurance does cover it. GI psychology, we're out of network for insurance, but we give the super bill, we give the codes with everything the patients need. They can go back and submit to their insurance as out of network. So all of this treatment falls under just therapy. So if your insurance company, reimburses you for any basically type of therapy, then it would reimburse you for this because that's what it falls under. Okay, any other questions? Yes. Okay. Let me unshare. Perfect. Okay, so there's Olga. Hey, Olga, do you have any questions before we start?
No, just go for it.
Cool. Okay, so there's two things that you can do to do better on these tests. And those two things are just focus and use your imagination. So you were saying earlier you've got a 6-year-old. So you know all about the kind of imagination that I'm talking about.
All right.
Now, I'm not talking about creativity. I'm talking about like what a little kid can do where they imagine something as if it's real, even though they know it's not real. Does that make sense?
Yeah.
Okay, so like as an example, if there were a dog, if you were just to imagine there's a dog nearby you right now, where would that dog be?
Next to me.
Okay. And then what does your dog look like?
See, this is hard because I actually have a dog in front of me.
Now you're just messing everything up. No, that's fine. So you actually have a dog right there next to
Literally
you?
right in front of me. He's an English bulldog. He's brindle. His face is white. His back is more brown, and he has a brown patch.
Nice. And if there was one more dog in the room, where would it be?
It would be a lab next to me.
Nice. And so if you were to just even imagine that that dog was really there right now, that's what we're talking about when we're talking about imagination. Okay. So the first test, there is a rule, and that rule is no scratching. So no scratching. Got it?
Got it.
Okay. So what I want you to do is find an itch somewhere in your body and let me know when you find it. And again, don't scratch it.
Okay. My nose.
Okay, perfect. And now what I want you to do is just using your mind, I want you to make that itch go away. And then when it's gone, I have a question for you. And so let me know when it's gone and just using your mind.
Okay.
You got it? Cool. So the question is, what did you do to make it go away?
I wiggled my nose.
Olga, no.
Eating? Try again. Sorry. Pick another person. I pass it to Kristen. She's laughing at me.
Oh my gosh, we're not going to give up on you so easily.
Okay.
Olga, now did I say use your mind or did I say wiggle your nose?
I mean, I use my mind to wiggle my nose.
That's so funny. Okay, we're going to see, because look, we might have the privilege of actually meeting someone who's terrible at hypnosis. This is possible because, again, we don't know anything about Olga's ability to use hypnosis. So this is a good one, and little kids like this. So what I want you to do is take your hands and put them together like this. And then you can kind of see, yeah, perfect. And then what I want you to do is focus really intensely on the space between your fingers. And then begin to imagine that there's something pulling those fingers together. Good. And just keep imagining that there's just something pulling. Yeah, nice job. And just keep letting your fingers just do what they're going to do.
But am I supposed to resist the pull?
No, just let the fingers do whatever they're going to do. Because what I've noticed is that they're making these little movements closer and closer. Good. Now what some people will, and just continue to just imagine that, Olga, and I'll talk with everyone else. Very interestingly, sometimes what you'll see is people's fingers will start to go together and then they'll just pull apart. And what I found over the years is that it's an indication that the person is beginning to feel a little out of control and they want to prove to themselves that they can move their fingers, right? And you're doing a great job, Olga. And by the way, in case I didn't mention it, but everyone else can kind of play along if you like too. So just keep imagining, Olga. Good job. And then when your fingers do finally touch, then just take your hands apart and let them go back to normal. Good.
All right.
So Olga, share with the group, what was that like?
They were like shaking the whole time. It's almost like I didn't want them to touch, but they still kept getting closer.
Yeah, and I don't know if I could tell just because it's on the screen, but sometimes you'll see these little jerky movements, and that means actually you're doing a good job. What those are called ideomotor movements, and they're an indication that you're not consciously making the movement, but it's coming from your unconscious mind. And so what a big part of learning hypnosis is about learning, how do I communicate with my unconscious mind? And the answer to that is through your imagination. So by imagining something was pulling those fingers together, it was giving your unconscious brain a signal to say, okay, let me start moving them very slowly. So let's do another one. You might need to back up, I'm not sure. One hand up like this, perfect. One hand down, then close your eyes.
Why is nobody else doing it? I'm just saying. Thank you, Kristen.
You need at least one person doing it with you. Okay, so in your right hand, there's a bucket. What color is the bucket?
Silver.
Silver, okay, good job. And then on the left, on your left wrist, we're gonna just tie a little string and then imagine someone slowly pulling up on that string. Good. And so what I'm gonna do in a moment is just start pouring some water in that bucket. And then let me know when you kind of feel a little bit of that heaviness. Good. Nice. And then I'm going to go over to the other hand and just pull up on that string, just nice and slow. Just pulling up on that string. And then we go back over to the bucket and we just pour some more water in there. Good. And then what I want you to do is just open your eyes and then look at your hands. Yeah, and then let them go back to normal. Yeah. So again, what was that like?
as the bucket was getting fuller, I felt like I couldn't hold my hand flat. Like I felt like I wanted to like grab it differently. I could feel that.
So as an example, this test is an interesting one for someone who comes in, let's say, with chronic pain or stomach issues or nausea or anything like that, in the sense that, Olga, just using your imagination, it sounds like you were able to feel a little bit of that heaviness from the bucket. Is that right?
Yeah.
Yeah. So just using your imagination, you're able to create a feeling in your body. And then we made that feeling go away. And what's that showing to people with these types of problems is the power of the mind to create feelings. But if we have the power to create those feelings, we also have the power to change those feelings, to modify those feelings. And that's where we talk about using clinical hypnosis to alter that visceral hypersensitivity. Because what is that? That's just amplifying a feeling. Well, guess what? We can turn it down. Oh yeah, so wait, Victoria. Yeah, Victoria sounds like a superstar on this one. So she was able to do it. She put something in the chat and her hands were pretty far apart. And that's also a good indication of talent. Another indication, often people will report, with their eyes closed, they didn't even realize how far their hands had gotten. And I don't know, what was your feeling on that? Did you know, Olga, know that your hand was lowering?
I didn't feel it at all. Yeah.
Yeah, and Victoria said the same thing. And that's another indication that you're doing well, because that movement was very unconscious. You weren't aware of it. So there's other tests that we could do, but I think this is a good stopping point. So I want to check in and just see if anybody else has any questions about what they've seen, and any of the other material also that we've talked about.
Yeah, so I wanted to go back to the finger with the space. You mentioned something about if someone is resisting, that's an indicator that they're trying to gain control. What is your assessment of that? Is that pertaining to somebody who may have had no control in their past, and so they're fighting that, or what would your assessment be of that if they're fighting the fingers? And by the way, my finger just went.
Nice. Well, I think when people do this, it can be a very weird feeling, because most people have not had the experience of deliberately eliciting ideomotor movement, which is unconscious movement. So to have your fingers moving and you not being the one that's moving them can be a very weird feeling. And so I think if someone has any issues with control, any anxiety issues, you'll often see that desire to kind of regain that control. And that's one way to do it, to say, okay, prove to myself that I can, make the fingers, that I'm not out of control. And that's something I want to emphasize to people throughout learning about hypnosis, is you are always in control. At any point, Olga could open her eyes, decide not to be doing what she was doing with her hands. At any point, Claire, you could have just been like, nope, my fingers are, yeah.
Right.
So it's not about losing control. Again, it's about learning to tap into your unconscious.
Right. So, but those who would resist control, they tend to have that feeling of my life is out of control, is what you're saying.
Yeah, or they're particularly sensitive to areas where they're
areas where they don't have. Okay, yeah, that makes sense.
So think about someone who's always trying to structure their life so they feel in control. They
Yeah,
never want to put themselves in a situation where it's unknown or they don't know how things are
Right.
going to work out.
Yeah, and that's my teen. That's the one I mentioned in the chat of who dissociates. So I'm curious to try this on her to see if she resists or how she
Yeah,
reacts.
it's a simple little test you can
Yeah.
just do to get an idea of if they'd be a good candidate for hypnosis. The other thing about ideomotor movement, like a lot of things, is that it's happening all the time. So an example is just body language. So if I'm talking with Olga and she's unconsciously nodding her head while I'm talking, that's an example of ideomotor movement. Now, I've made it explicit to her now, so she's not going to do it unconsciously anymore. She's going to be super aware of her head and any head motions that she makes, but she might not be aware of what she's doing with her feet. She might not be aware of what she's doing with her hands. So our body is constantly doing unconscious movements. And this is just, we're just kind of tapping into that capacity when we're doing this.
This has been awesome. Thank you so much. And I'm really glad we got to the end part because I think it was cool to kind of see how it all comes into play. But thank you for coming on a Friday. Everybody's joining. Thank you, Dr. Navidi, for being here and sharing your knowledge on this, answering all these incredible questions. Thanks everyone for participating. And I hope you all have a great weekend. I will send out the recording by Monday at the end of the day. That is my deadline to get it out to you guys. Any resources that were mentioned today too, I'll send those out. So look forward to seeing you all again soon, I hope. And take care.
Thank you so much.
Bye.
Great. Thanks for the opportunity. I appreciate it. I had fun.
I'm so glad. This was a lot of fun. Thank you.